of development. The term central skull base refers to anterior skull base, which is made by the ethmoid and portions of the frontal bone, and the middle skull base, which is made by the sphenoid bone and clivus. The anterior and middle basic cranium make the central skull base, and the area is full of imaging variants that may be mistaken for pathology in the pediatric age. This imaginary line describes the delineation between the anterior skull base, which is made by the ethmoid perpendicular plate of ethmoid bone here, and the sphenoid bone posteriorly. The pattern of ossification and development is in orderly fashion from posterior to anterior. So the clivus ossifies first, followed by the sphenoid bone, and lastly the frontal bone or the anterior skull base, which is ossified later in the first year after life. This is the development of the skull base, central skull base. This is different from the remaining calvarium and remaining facial bones, and the difference is that skull base develops from the mesenchyme, which then later on replaced by cartilage, in contrary to the membranous mesenchyme, which is making the calvarium and facial bones. These cartilages are made of or containing ossification centers, which ossifies orderly from posterior to anterior fashion. So we have this clivus made of multiple different segments, which ossify later on by ossification centers. We have the post-sphenoid and the pre-sphenoid cartilage. The demarcation between them is at tuberculum sella. So the pre-sphenoid is anterior to the tuberculum sella, and the post-sphenoid is posterior to the tuberculum sella, and this suture between them is called the cranio-pharyngeal canal, while this area is the spheno-occipital synchondrosis. The spheno-occipital synchondrosis is the last to ossify, and usually ossification is delayed until later in age, even delayed until adolescent and adult life. This is the images in neonates and in adolescents showing this segmentation. This is a portion of the obliterated cranio-pharyngeal canal, and this is spheno-occipital synchondrosis, which is still open at this age. This is the pattern of fetal ossification from posterior to anterior. These images are taken as MRI images taken from fetal specimens which have been dead. These images showing from 20 weeks gestation, and this is 22 weeks gestation, showing how these centers are fully developed posteriorly before anterior. This ossification of the clivus, followed by the post-sphenoid and pre-sphenoid, and this is developed more here in this delayed 22nd week, showing this clivus is more developed, followed by the post-sphenoid and then the pre-sphenoid, the last hypophysis. The development of hypophysis made by the neuro and adenohypophyses, which fuse adenohypophysis coming from the diencephalon and the adenohypophysis coming from the thoracic pouch, and then the development of the sphenoid bone, or this of the pre and post-sphenoid, is linked to the fusion of the hypophysis. So the pre-sphenoid, or called hypophyseal cartilage, is anterior to the tuberculum sella, and the post-sphenoid cartilage is posterior to tuberculum sella. They develop and fuse together once the pituitary gland is fully developed. And this suture is called, or this canal is called cranio-pharyngeal canal, and this is usually obliterated. And so any development anomalies of the pituitary gland is strongly linked to the post-sphenoid, to the abnormalities of development of the cartilage. So this is the normal appearance of the central skull base in pediatric adults. We have this patent spheno-occipital synchondrosis, which is the last to close. This is the images. This is the first variant, which we must be oriented in appearance of the CT images of the pediatric age. This is the appearance of the 6 months, showing the persistent spheno-occipital synchondrosis. This is normal development because it takes time to close, showing a progressive narrowing of the spheno-occipital suture, and there is a central canal here showing an obliterated vessel. Further growth at age of 10 years, and then lastly at 14 years. This patient had a fusion of the spheno-occipital synchondrosis, but still it may be persistently till the age of 18 or even to 20. So this the first variant of the middle skull base. Then we come to the second variant, which is craniopharyngeal canal. Sometimes a craniopharyngeal canal may be appearing persistent, and this is usually associated with mid-facial clefting, basal cephalocele, ectopic glioma, or hamartomas, or intraosseous Sclerotic cleft cyst, dermoid, or macroadenoma. This is the normal appearance of the craniopharyngeal canal. It's appearing like here. This is the sphenoid and it is anterior to this synchondrosis, appearing here as vertical line of obliterated canal, or it can be appearing as a dot or a point representing the obliterated craniopharyngeal canal. This abnormal craniopharyngeal canal, which is persistent, clefting here, and there is a descent of the pituitary gland, and this coronal image showing clefting, and this is abnormal development, and this is usually linked to the pituitary gland abnormal development, like ectopia of the pituitary. The third variant is olivary eminence, which means an area on ossified cartilage at the site of the pre-sphenoid, which is the cartilage anterior to the periculum sella. So when it ossifies, it may leave an area of partial ossified area like here, surrounded by sclerotic margin. Sometimes it be more widened like this area, and this is a usually normal variant and shouldn't be mistaken for anomalies. The fourth variant is medial basal canal. This is related to the development of the notochord. Here, the three lines by order here, the craniopharyngeal canal we have discussed, the sphenoid and the median basal canal. This notochord, which is traced from the center of this the vertebrae, coming here into the skull base, showing this curved pattern. It runs into this craniopharyngeal canal, and this craniopharyngeal canal is, median basal canal is obliterated. Sometimes it may be patent. The paracordal cartilage means the segmentations here, or the cartilages around the cord. And this is responsible for the formation of the basal sphenoid around the notochord. So sometimes these paracordal cartilage, when ossified, leave this median basal canal non-obliterated and may be persistent and may be mistaken for imaging pitfalls. So the median basal canal, when it is open, it may be a linear structure like this, called median basal canal, or it may be leaving something depressed like here, and it is called fossa navicularis magna. So again, craniopharyngeal canal, the sphenoid and the median basal canal. The fifth variant is arrested pneumatization of the sphenoid bone, or fatty lesion of the sphenoid. Here we have the column of Burton at the side, just at the side of pterygoid plate and on both sides of the vomer, and these are the precursors of the sphenoid pneumatization. The process of pneumatization is undergoing a conversion from the red marrow to the bone to the fatty marrow, and then lastly, this is invaded by respiratory epithelium to achieve pneumatization of the sphenoid bone. So if this failed, and failure of the process is usually is at the step at conversion from the fatty marrow to the pneumatization. So this leads to what is called arrested pneumatization of the sphenoid bone, appearing like these areas here, maybe mimicking hemangiomas, or maybe even a more fuzzy-like appearance than this, and they may be mistaken for lesions. In MRI, this is shown as T1 hyperintense signal because it is full of fatty marrow and non-enhanced, and it is hyperintense relative to the skull base. So this is the last variant. Then we come to the anterior basic cranium, which is made by the frontoethmoidal bone. So this is the normal by MRI, showing the cartilage here. This is non-ossified, and this is normal. So the first variant of the anterior skull base is unossified frontonasal cartilage in infants. The non-ossified process of the frontal bone, nasal bone, ethmoid bones have CT attenuation similar to the brain parenchyma and nasal cartilage in the first 6 months to 8 months of life, and even may be persistent until the age of 1 year and even 1.5 years. So we are having here the normal newborn, complete absence of any ossified bone. And this is at age of 2 years, this is the normal developed bone. Again, here we have non-ossified bone. This shouldn't be mistaken for defects or abnormalities of development, and this appearance shouldn't be investigated by CT only to check for cephaloceles or others, and the imaging modality of choice is MRI. The second variant is crista galli. Signal is not fatty. Actually, this is images of T2 showing hyperintense signal because it is made of cartilage, and cartilage may contain hyalinized areas. So this appearance of signal shouldn't be mistaken for any pathology. This is the normal development of crista galli in the pediatric age. This is the sequence development of crista galli, appearing as just linear structure, which is very hypo-intense. And lastly, it is developing as a cup-like appearance or a polygonal appearance, and it is fatty, while here there is no fat signal in the T1 signal, in the T1 sequence. Then this is the complete normal imaging later on, showing the fat signal very hyper-intense. Lastly, the anterior neuropore anomalies. The anterior neuropore is made of, here is the cleft of a called fronticulus frontalis between the frontal bone and the nasal process of frontal bone, and this is closed by a membrane. Also there is the prenasal space between the frontal nasal process of frontal bone and the ethmoidal perpendicular plate. A process of diverticulation extends here in the prenasal space and the frontal nasal process. Then lastly, it is obliterated. So we have the three areas of fronticulus frontalis, prenasal space, and the foramen cecum here at the apex, at the base of the diverticulum. So the first variant which can be encountered is the foramen cecum. The normal appearance of the foramen cecum is to be narrowed like this, having sclerotic margin, and here it is appearing as a narrow canal, and here the sclerotic margin in more adult life. By MRI, showing here as a sclerotic margin, and it is here ethmoidal and nasoethmoidal. So cephalocele here is extending in the prenasal space, and here it is extending through the fronticulus frontalis. The cephalocele associations also have to be looked by MRI, so MRI must be taken in every case. These include agenesis of the corpus callosum, interhemispheric lipoma, schizencephaly, and holoprosencephaly. The third of the anterior neuropore anomalies is nasal clioma, and it was discussed yesterday. An important thing in NMR imaging of anterior neuropore, we have to take into consideration to adjust the imaging technique. Fat lesion of the